Hey guys, it's Dr. Barone. I'm still in Chicago. I got the L behind me. Hopefully you see the train a couple of times. And I want to do a little tape on peripheral nerves and muscle pathology. Now there's still a lot of cool stuff here. And again, I gave you the big picture here so we can see what's coming. We'll talk about disorders of peripheral nerves like diabetes and vasculitis. We'll talk about Guillain-Barré. And if I make it red, it's because it's high yield. I love that one. We can also get some points on Charcot-Marie tooth. Get a couple points there too. Now then we're going to move to the neuromuscular junction. Here we have two things, myasthenia gravis, which is super high yield, and every once in a while they ask about Lambert-Eaton, which is usually associated with lung cancer. So you give some points that way. And then finally we'll finish up with disorders of muscle. We'll start with inflammatory ones like dermatomyositis, polymyositis, and inclusion body myositis. And then we'll finish up with the inherited muscular dystrophies, the ones they do the telethons for. So Duchenne's and Becker's and myotonic dystrophy. Now again, I want you to pay close attention when I get to Guillain-Barré, myasthenia, dermatomyositis, and Duchenne's. Those are going to get us the biggest yield. So let's get right into it. Peripheral nerves and muscles, they work together. In fact, the muscle is a slave of the nerve. When the nerve says jump, it contracts. It contracts. So let's get right to it. Let's talk about some skeletal muscles. Now let's start with normal. We all know that there are two types of skeletal muscle. There's type 1, which is slow twitch, and there's type 2, which is fast twitch. Most students will memorize it, forget it, memorize it, forget it. So I want to get it tattooed to your brain. So I want you to imagine a person standing at attention. They're standing up like a number 1. So let's make a number 1, Roman numeral number 1. Let's make it number 1. And then we'll put a head on it. So it's like a dude standing here at attention, like a number 1. Yeah, to stand with this posture, I need my postural muscles. So type 1 are going to be your postural muscles. Now I can stand all day. I'll wait for your answer. Is it going to be slow twitch or fast twitch if I can stand all day? It's going to be slow twitch. If it was fast, you'd poop out. So type 1 are slow switch fibers. They give you slow, sustained contraction so I can keep this posture all day. Now let's talk about energy. If I'm going to stand all day like that, I need a lot of ATP. So I'm going to have aerobic metabolism like a marathon. I'm going to burn fatty acids in the Krebs cycle and make lots of ATP so I can stand all day with sustained contraction. Make sense? Oh, there's the L. Elevated train. Now, to do aerobic Krebs cycle, you need mitochondria. So a type 1 fiber is packed with lots of mitochondria. And remember, mitochondria have cytochromes, which have iron, and they have myoglobin, which has iron. So what is this going to look like grossly? It's going to look red because that's what iron does. It makes red cells red, it makes liver red, and it's going to make the muscles red too. So this is the red meat. So if you have turkey or chicken and you ask for the dark meat, you're asking for the type 1 slow twitch fibers. Yeah, so you can impress your dinner date. Say, hi honey, can you pass me the type 1 slow twitch muscles, please? Oh, I'm sorry, the red meat. Do you know why it's red? Because it's got iron. You can impress your dinner date. So turkey and chicken. Now, when you ask for red meat, it tastes good. Right? Those hamburgers, the hot dogs, they taste good. Red meat tastes good, but not healthy for us. Why? Because the energy source is fatty acids. This is a very fatty muscle, so it tastes good to us because of the fat, but it's not very healthy for us. We're supposed to eat lean white meat. It's leaner, like the white meat, but the red meat tastes so good, and that's the reason why. Now let's talk about type 2. Before I got smart like you and became a doctor, I was an amateur boxer. I fought in the Golden Gloves. Yeah, and I'll never forget my boxing days. So here's the boxer, and notice the 2 arms. 2 arms to go fast. 2 arms. So let's go Roman numeral 2. 2 arms, fast twitch. Fast twitch. It's fast. Boxers go fast, fast, fast. So imagine a boxer hitting a speed bag going really fast. Really fast. So type 2, fast twitch. So for quick bursts of movement, short quick bursts, you want type 2. It's fast twitching. Now the problem is I can't wait for the Krebs cycle. If I'm going to go fast, I need energy now. To do that, I'm going to go anaerobic glycolysis. So I'm going to burn glycogen. That's what I'm going to use here. Glycogen is going to be my energy source, and that'll get me sugar. That'll get me energy real quick. Now the problem is anaerobic glycolysis doesn't make as much ATP, and the byproduct is lactic acid. So unfortunately, you can't go fast all day. You're going to burn out. You're going to get lactic acidosis, and you're going to get cramping. So if you watch the MMA fighters, in the third round, it looks like they're in slow motion. They're punching so slow because they're all cramped up from going fast for 2 rounds. In fact, in between the rounds, you always see them straight, shaking their arms out. They're trying to get the lactic acid out of their arms because it builds up and they get cramping. You can't go fast forever. It's the problem. So to get energy quick, I go anaerobic and I create lactic acidosis. Now, do you need mitochondria? Do you need mitochondria for anaerobic? No. So there's very few mitochondria. There are some, but very few. So on gross, it's going to look like white meat. This is the white meat. And notice, it's healthier because it's not fatty. It's got glycogen. So it's a leaner, it doesn't taste as good as the red meat, but it's healthier for us. Okay, isn't that cool? Perfect relation of pathology and dinner. All right, now let's get to some board questions. This is normal. Here's what I need to know from you. I have 2 muscles here. Okay, so let me draw these muscles. Here's one muscle. Here's the other muscle. These are muscle fibers. Okay, this is a type 1. This is a type 2. How does the muscle know what to be? How does it know? Should I be a type 1 fiber or a type 2? How does it know? The muscle's a slave to the nerve. The nerve tells it what to be. So this gets innervated by a motor neuron. That's a type 1 motor neuron. It will tell it to be a type 1 muscle fiber. This is going to be a type 2 motor neuron, and that's going to tell this to be type 2. So the muscle is a slave to its nerve. So here's a famous U.S. Assembly question. I'm dissecting a dog. I got a type 1 muscle fiber here, a type 2 here. I take the nerves and I switch them. What will happen? Well, if I switch the nerves, the muscles will switch their fiber type. The type 1 fiber will now become a type 2 fiber, and the type 2 will become a type 1. It will literally change. Type 1 will now develop a lot of mitochondria and start working aerobically. If it turns to type 2, it will now become anaerobic. It'll make a lot of glycolytic enzymes. The nerve tells it what to be. That's so cool. So a nerve is really in charge. It tells the muscle what to be. All right, now let's talk more pathology. Here is a neuron. Here's the cell body. Then we have the axon, which is going to bring the signal down to the nerves. And notice, down to the muscle. Notice, one motor neuron is going to innervate multiple muscles. So one nerve, multiple muscle innervation. And all those will be the same fiber type. So pretend this is a type 1 fiber. So type 1 fiber, type 1 fiber, type 1 fiber, type 1 fiber. Whatever it innervates will be type 1 because it tells it what to be. Now, to speed the conduction, we want our nerves to be myelinated. We want to have myelin. So in between are going to be these nodes. We call these the nodes of Ranvier. Okay, so the Schwann cell is what does the myelination of our peripheral nerves, and then in between is the nodes of Ranvier. Now we want them far apart because I want the signal to jump from one node to the next node to the next node. This is called saltatory jumping, and that will speed the conduction up. If there's no myelin, then it's got to go. It's got to go down the whole thing. It takes forever. But if you put myelin, it jumps from one node to the next node. It goes really fast. So that's why we want myelination, to speed the conduction. Make sense? All right, now let's talk about some pathology here. Okay, what if I get axonal injury? What if I get a knife and it cuts the nerve? Well, what happens downstream from that? Because here's the nucleus. This is what's synthesizing all the proteins. Well, guess what? Now it's cut. So this distal part is going to die because it's not going to get any of those proteins anymore, because you cut it. So you're going to get axonal degeneration. We're going to call this Wallerian degeneration. So the distal axon will die. It'll die, okay? And then, of course, you're going to get what's called denervation atrophy. These fibers that used to be innervated are no longer innervated. So the muscle's like, stimulate me, stimulate me, stimulate me. And you get denervation atrophy. They get small as well. They start twitching, you get fasciculations, and they denervate. They denervate. Now, here's the good news. What if the neighboring fiber will start to innervate it? What if this sends off little branches and innervates it? Oh, well, now it will grow back. Now they'll start getting big again. But what fiber type are they going to be? Well, now they're going to change. See, this was a type 1 originally. This was a type 2. So now they're going to turn to type 2. And so what am I going to see? Fiber grouping. I'm going to see fiber grouping. Because normally our muscles should look like a checkerboard. You should have type 1 muscles intertwined with type 2. They should be all like checkerboard. But now you're going to see all of these are going to be type 2. That is called denervation, reinnervation injury. You start to see fiber grouping. I'll show you a picture of it on the next slide. But I just want to bring that up because that's so cool. When you cut the nerve and then a new nerve grows in, those fibers will regrow back, but they'll change their fiber type based on what innervates them. Now, another way I can get pathology, so this is pathology to the axon, axonal injury. I can also have demyelinating diseases that attack the Schwann cell, something like Guillain-Barré. Well, if I kill the Schwann cells, the axon's still good, but you're going to slow your conduction. Conduction is now going to be slowed. So now you're going to have weakness, not because of the muscle, because the nerve, because the signal is going to be slowed. So you're not going to contract your muscles as quickly. Okay, so you're going to get weakness because of demyelination of the Schwann cells. Now, good news, since the axon is still there, could it remyelinate? Yeah, so it's going to remyelinate. Now, tell me what's wrong with these areas of remyelination. Well, notice, nothing as good as what the Creator gave you originally. So I'm going to remyelinate it, but it's going to be thinner. Notice it's not as thick. The myelin is thinner. And the nodes, the internodes, are going to be shorter. So now you're going to get better, but it's going to take a little bit longer to get down there because this is thinner myelination, less insulation, and there tends to be shorter intervals between the nodes. So again, remyelination, you get better, but you're never going to be 100% better. That's the problem with remyelination. You get better, just not 100%. Okay, so axonal injury, you kill the axon, downstream dies, you get atrophy, hopefully you get reinnervation. If you have demyelinating diseases, you lose the myelin, you lose function for a while, then it remyelinates, your function goes back, but it's never quite 100%. Now, here's another example of denervation, reinnervation. Normally, we should see a checkerboard pattern. We should have type 1 fibers and type 2 fibers kind of interspersed. And here's what it looks like with a real picture under a microscope. So again, we have these paler fibers and these darker fibers. It's basically a checkerboard. That's what muscles should look like. Now, if I get denervation, I get damage to the axon, this denervates, I damage this one, it denervates. Well, now these guys are going to become small. This one becomes small because they're denervated. Now, hopefully you get reinnervation and regeneration. So these surviving ones are going to try to innervate. When they do, these fibers are going to change from their type 1 to their type 2, and vice versa, type 2 to type 1. So they're going to have what's called fiber grouping. So if you look at this picture, notice the way you have a big group of fibers here that are all the same color, a group here that are all the same color, a group here, you'll lost that checkerboard appearance. So this is called fiber type grouping. Usually the answer is denervation, reinnervation. That's usually the answer. That's what they're going to be looking for. When you see checkerboard goes to a fiber group pattern. All right, now what about diabetics? Well, diabetics is the #1 cause of peripheral neuropathy in the United States. Yeah, it's the most common cause of a generalized peripheral neuropathy in the US. Now, it usually affects distal, as we mentioned in the last tape. The longer the neurons are, the more likely they are to lose their myelin. So it usually gives you a glove stocking distribution. It's usually symmetrical, and it's sensory and motor. Now, sensory is affected first. So it's usually glove stocking sensory loss first. And then later on, you get more muscle. But sensory is usually affected first. Then you get motor. Now, the length is going to depend, or the longer it is, the more likely it is to get degeneration. So that's why they call it a glove stocking sensory loss, because the distal gets involved. Now, you lose pain and sensation. Now you're going to get injury of your toes because you can't feel them. So now you jam your foot in it, you don't feel it. You get a cut, you don't feel it. You don't take care of it. Now, if you don't take care of that cut, it's going to get infected. And it's not going to heal because they don't have good perfusion. They have atherosclerosis from diabetes. So they get these non-healing ulcers, and eventually you may have to amputate. So that's not good. Once diabetics get these ulcers, they don't heal, they keep getting infected, you don't end up amputating. And once you start amputating, now you're bedridden, you're in a wheelchair. Now the other foot's going to get injured. You have to amputate that. So once you start amputating, it's like a downward spiral. Not good. So I always train my diabetics. When I see you, I want to see your feet. I always, it's like, do you have a foot fetish? No, I take care of diabetics. I got to check their feet, make sure I take care of any injury there, heal it quickly so they don't get these ulcers that never heal. Now, in addition, they also get not only peripheral, but autonomic neuropathy. So diabetics, they get a lot of constipation. They get what's called gastric paresis, where they just don't move their bowels. And their bladder, they get neurogenic bladder. They get cardiac and sexual dysfunction, like impotence, not cool. Yeah, pointing and shooting, I like pointing and shooting, so unfortunately, to point, you need to have parasympathetics. To ejaculate, to shoot, you need sympathetics. So unfortunately, you start losing that. And they also tend to get postural hypotension. So when they stand up, they get hypotensive because the autonomics control that. So they get lightheaded when they stand up quickly. So diabetics and neuropathy, big problem. All right, now what about vasculitis? Well, you can also affect your peripheral nerves because blood vessels give oxygen to nerves. So when you have a vasculitis, you can get a neuropathy from it, okay? So peripheral nerves may be damaged by systemic vasculitides like polyarteritis, Churg-Strauss, Wegener's. And when they get neuropathy, it's usually kind of local. They call it a mononeuritis multiplex. So it's usually in one or two areas, and it's not just one, it's multiple areas, but it's local. It's asymmetrical, and it's often painful. Painful, asymmetrical, sensory and motor dysfunction. Sensory motor. Now if we take a look here, here's a vasculitis. Notice here's the artery. Notice all the inflammation around it. So here's the problem. When I inflame the artery, now the artery is going to get occluded, it's going to get thrombosed, you're going to get ischemia. So these poor nerves that are nearby are not going to get their oxygen, and they're going to demyelinate. So here's a nice fiber that's nice and myelinated. See how dark it is? Now look at this fiber. It's demyelinated. And when it remyelinates, now it's thin. And notice the nodes of Ranvier are now closer together. Before, the node was here, the node was here, nice myelinated fiber. So the electricity is going to jump. Well, after it demyelinates, when it tries to remyelinate, it's thinner. I think you can see it's not as dark. And the nodes are closer together. So now it's going to take longer. So again, I'm going to have a little bit of a deficit here. So I get ischemia in my nerves, they demyelinate, then they remyelinate, and they're not quite as good. So here's an example. This is a myelin stain. Notice you don't see much dark staining here. Over here, you see a little bit more dark staining. A little bit, this is myelin staining. But basically, it's mostly demyelinated. So you demyelinate these nerves, you're going to get neuropathy. Painful, asymmetrical neuropathy. All right, now, highest yield for this section is inflammatory neuropathy. So inflammation leading to neuropathy. We call this Guillain-Barré. It's an autoimmune attack. Now be careful, because everybody calls it Guillain-Barré. So what does the board call it? The other name. Acute inflammatory demyelinating polyradiculoneuropathy. So it's going to affect the nerves and the nerve roots, multiple areas, and it's going to have demyelination because of an autoimmune inflammatory attack. So it's actually a really good name. It's a really good name. So if we take a look here, this is an autoimmune disease where you get rapid progressing immune-mediated demyelination. Now, if we remember, what myelinates peripheral nerves is our Schwann cells. So this is your immune system attacking your own Schwann cells. Now, the cousin disease. What's the cousin autoimmune disease where you attack your own central myelin, your oligodendrocytes? That's called multiple sclerosis. So that's like the cousin, kissing cousin. Autoimmune disease attacking CNS, MS. Autoimmune disease attacking peripheral, the Schwann cells, that's Guillain-Barré. So they're kind of related diseases, both attacking myelin, but different location. Now, what's going to trigger autoimmune diseases? Well, if you have the right HLA and you get exposed to some environmental trigger, you can attack your cell. So we think it's usually triggered by infections or sometimes vaccines. That's one of the reasons why people are like anti-vaccine, because sometimes when you get vaccination, people can develop Guillain-Barrés. But again, I think the risk of it is pretty low. So preventing vaccine diseases, I think, is more important. But there will be people who will refuse the vaccines because of this complication. And we should always respect what people's rights are. I know we'd like to vaccinate everyone, but people are in charge of their body. They're in charge of their body. So I don't think the government should mandate it, because in California, they've mandated it. They will not let your kids go to school unless they get the vaccines. I mean, the thought is in the right place. We want people to be vaccinated. We want them to be vaccinated, right? That's a very important thing. The vaccines are excellent. There's no polio because we vaccinate, okay? But there are side effects. So I don't think the government should mandate it. I think it should be recommended. I think we should explain to them the risks and the benefits, but I think people should still be able to make their own decisions. But again, that's my opinion. What the hell do I know? Let the government get in your bedroom and regulate what you do in your bedroom. Not me, not me. I say government, get out. Okay, anyway, stay away from politics. That's why I stay away from politics. All right, now, what infection is triggering this? Well, a lot of times it's a virus. So Epstein-Barr, CMV, HIV, but bugs can do it too, mycoplasma. But here's the big one. 30% of the time, Campylobacter jejuni. So you get a bloody diarrhea first, and then you wind up with a neuropathy. Okay, so again, look for that history. I had a bloody diarrhea a few weeks ago. Now I'm coming in with weakness because my nerves don't work, my muscles are weak. All right, now why is Campylobacter going to cause it? Molecular mimicry. Some people can look like the bug. So I attack the bug, I attack myself. So molecular mimicry is the term we use when our immune response is supposed to attack the bug. We're attacking the lipopolysaccharide antigens on the capsule of Campylobacter jejuni. But those antibodies can cross-react with my own Schwann cells, the ganglioside G1, which is located in the myelin of the Schwann cells. So I attack Campylobacter, I can attack my own peripheral myelin. So that explains why a bug can cause me to attack myself. Again, it's only 30%, but they really expect you to know Campylobacter and Guillain-Barré. But most cases are viruses. Most cases are virus-induced. Now, under the microscope, this is an inflammatory neuropathy. So we expect to see inflammation with lots of lymphocytes, and then macrophages are coming in to eat all the myelin when it dies. And you'll see segmental areas of demyelination of the peripheral nerves and the nerve roots as well. That's why the muscles are weak. The muscles are fine, but they don't work because the nerve doesn't work. So they're a slave to the nerve. So I want you to remember this as an ascending muscular weakness. It's an ascending paralysis. See, it's the muscles are weak because the nerves. So the axons are still there. It's the myelin that's lost. So you can get better. You can remyelinate and get your function back. Whew. Thank goodness. So this is potentially reversible. You may be left with some deficits, but but you can get better, thank God. Axons are spared here, it's demyelinating. Now, clinical, it's usually a symmetrical muscular weakness, but it's only weak because it's the nerves. It's really a paralysis. And it tends to affect the distal first, so you usually get lower extremity first, and then it rises and gets more proximal until finally it can get to the respiratory muscles and potentially kill you. If your diaphragm doesn't work, you can die. We'll have to put you on a ventilator. Now, since it is a nerve problem, what's cool about this is they lose the deep tendon reflexes. So that's important because some of the muscle diseases we're going to study later are going to have weak muscles, but the deep tendon reflexes are not affected because it's not the nerves. This is a neuropathy. So look for that clue. Muscular weakness with loss of deep tendon reflexes. Now, it can also affect autonomic, so you could get arrhythmias, you can get hypotension, you can get hypertension too. Now, what else can involve? The respiratory muscles, and that can lead to death. So when they start getting weakness and trouble breathing, that's when you want to consider intubation and mechanical ventilation. You may have to breathe for them. Yeah. Now, it's very sad. A friend of mine, we were living in LA, a friend of mine got on the game show, and she actually won. She won a trip to Hawaii. She was so excited. She went out. They were partying. They were celebrating because she's going on this free trip. So excited. Well, she was partying, hanging out with a lot of people, and she got like a cold. She got like a virus. So she got on the plane with this like flu, this virus. Then when she landed, like 2 days later on the beach, she started getting all weak. She's like, I was like exhausted. I couldn't move. I went to the hospital. I couldn't breathe. They intubated me. She had to go on a ventilator. So she was in the hospital there for like 3 weeks. Finally, they were able to extubate her, and her weakness went away, because usually remyelinate, you get better. The weakness went away, and then she flew home and she said, I'm never going to Hawaii again. I spent the entire time in the hospital. I was on the beach 2 days. So I guess the moral of the story is if you go on a vacation, make sure you don't get sick before you go, because that's what happens. You got a virus, and it triggered Guillain-Barré. Yeah, she had to be on a ventilator. Now, thank goodness most people get better. There can be some residual, but most people get better. Now, for the laboratory, what you want to do here is see the nerves are not working. So you want to do nerve conduction studies. And without myelin, you're going to see a decreased nerve conduction velocity. Now, if you do a spinal tap, you're going to see inflammation, and you're going to see a lot of proteins because of the myelin breakdown. So increased protein in the CSF because of the inflammation and demyelination. All right, now for treatment, one of the things we tried is plasmapheresis to try to remove some of the antibodies that are attacking you. And then giving IVIG can help too. How it works, we're not sure. So get rid of their antibodies, give them new antibodies, and of course, ventilator support, get them on a ventilator if they get weak. Now, most people are going to get better usually in 2 to 4 weeks after the onset of weakness. So it usually takes about a month. Viruses go on their own. When they go on their own, the immune system stops attacking itself. So she got better, but she said, I'll never go to Hawaii again. Poor thing, I felt bad for her. All right, now this one is lower yield, but I want you to know it because it's the most common hereditary neuropathy. Hereditary, it's genetic. Hereditary neuropathy in children. And it's kind of cool. It's got 3 names, Charcot-Marie Tooth. Pretty cool. So they often ask it because it's just an interesting disease. Now, this is a distal, sensory, and motor polyneuropathy. So multiple nerves, and it's sensory and motor. But it usually affects distal, especially the lower legs. Very common. Now, when the kids are born, they're usually good, but as they get older, they tend to get weaker and weaker. So it usually presents in childhood or early adult life. They start coming in with this weakness. Now, there's 2 forms. The most important form is type 1. This is a myelin problem. Type 2 is more of an axonal problem, but I've never seen them ask that one. So let's do type 1. Type 1 is the most common. Okay, it's a dominant duplication in the PMP22 gene. What does PMP stand for? Peripheral myelin protein. Oh, the myelin. So it's a genetic mutation in myelin. Oh, neuropathy, got it. Myelin problem, got it. So I want you to remember duplications of PMP22. So I kind of think of it like pimp, a 22-year-old pimp, because it's an early adulthood, early adult. So 22-year-old pimp walking with a cane, walking with a cane. They got a problem with their lower extremities. They walk funny. So I'm making a joke out of it, but it kind of helps me. 22-year-old pimp walking funny with his cane. Now, since the myelin is defective, you often see these swollen, dilated areas of myelin. These are called onion bolls. Onion bolls is just layers of Schwann cell myelin just accumulating like an onion. It's got layers. That's a characteristic feature here, onion bolls, from the problem with the myelin. And of course, this is going to lead to demyelination. Demyelination, so you're going to get sensory loss, so distally you're going to lose sensation, and you're going to get muscular atrophy because it's motor too. So that winds up with foot drop. That's why they walk funny. They're going to be dragging their foot drop. And they also tend to get deformities too. So if you take a look at this poor guy, first of all, look at the muscle here. Really atrophy. So I like to remember toothpick legs. Toothpick, they're like toothpicks. They're really thin. And since it's so weak, they tend to get these deformities. Do you see this? This is called pes cavez, a high arched foot. You can also get hammer toes too. So I remember toothpick legs with pes cavez. Toothpick legs with pes cavez. And then look at the arch, man. That's like the London Bridge. That's a big arch. So they're gonna have trouble walking here. They're gonna have trouble walking here because of this weakness. Okay? So 22-year-old pimp, he's walking funny. He's got this atrophy, toothpick legs, and pes cavez. I'm gonna sing you a song. I'm gonna sing you my pimp song. Yeah, I changed. What is it? What's his name? 50 Cent. I changed his big pimpin' song. I changed his pimpin' song. So I'll send you that video so you can remember this one. Shotgut Marie Tooth. All right, now let's talk about some neuromuscular junction problems. Oh man, these are big time. They love these. Myasthenia is huge, and every once in a while they'll ask about lung cancer causing Lambert-Eaton. Now, for myasthenic syndrome, myasthenia, weak muscles, myasthenia gravis, grave weakness of muscles, grave weakness. Now, this is an autoimmune disorder where you make antibodies against the ACH receptor. Yeah, now that's not good enough. Everyone knows antibodies against ACH receptor. You have to be more specific. So here's the nerve ending. Here's the muscle membrane. So this is the neuromuscular junction. Where's the ACH receptor? Well, it's not presynaptic, it's postsynaptic. It's on the muscle membrane. It's on the muscle. So this is a postsynaptic muscle membrane. But what is it really? It's a sodium channel. So it's a ligand-gated, the ligand is ACH, that's the ligand, ligand-gated sodium channel. Don't get mad at me. Everyone memorize it as antibodies against ACH receptor. You look for it, it won't be there. It'll be antibodies against the postsynaptic ligand-gated sodium channel. Man, how do they figure these things out? They always want to know, how does every receptor work? How do channels work? So this is a receptor for ACTH, or sorry, receptor for ACH, which is a sodium channel. That's how it's going to bring the signal in. Very cool. All right, now what type of hypersensitivity? If I know the exact target like this, type 2. Type 2. Now, very important association. 60% will have thymic hyperplasia, 20% will have thymomas. So always get a chest x-ray and look for a shadow. If there's a thymic shadow, you should remove it because either it's thymic hyperplasia or thymoma. Now, thymoma is a tumor of the thymus. What's a thymic hyperplasia? It's mutiny on the body. B cells have come in and they've taken it over. You're going to see follicles, germinal centers. B cells are there making antibodies against your junction. So if you remove this thymic hyperplasia, you're going to remove a lot of the B cells that are making the antibodies. So you're not going to be cured because there'll be B cells in other areas, but you're going to get so much better when you do the thymectomy because that's a source of a lot of the antibodies. So again, always look for thymic enlargement. If you see it, you should remove the thymus because they're going to get greatly improved. Now, clinical. Who gets autoimmune diseases? Women in the reproductive age. So this is most common in women in the reproductive age. And it usually affects the small muscles. The small muscles, particularly in the face. So very common to get weakness of the extraocular muscles. So by the end of the day, the more I use them, the weaker they get. So it tends to get worse at the end of the day. The more you use it, the worse. So at the end of the day, you say, Doc, I can't keep my eyes open. I'm getting ptosis, and I'm getting double vision. I can't keep my eyes in the same direction. So double vision and lid droop at the end of the day is absolutely classic. It's classic. The more they use it, the weaker it feels. So myasthenia patients want to sleep because in the morning, they'll be fresh again. They want to sleep because in the morning they feel better. At the end of the day, they're the worst. They want to sleep. Now, if you get a crisis, this can involve respiratory muscles, and that can lead to death. Because if your muscles don't work, you're going to get atelectasis. That's a culture plate. You're going to get pneumonia, and you're going to die. So let's repeat. Whenever crisis, they can have atelectasis leading to pneumonias here. So very important. If they get a crisis, watch for pneumonias and treat it. Now, to make the diagnosis, one of the things we can look for is the antibodies. Let's look in the blood for anti-acetylcholine receptor antibodies. They're present in most cases. Now, there also are other antibodies too. You can look for anti-striated muscle antibodies or anti-muscle specific kinase antibodies. So these are pretty good too. But the best one to look for, diagnostic one, is the antibodies against the postsynaptic ACH ligand-gated sodium channels. Now you can also do electromyography, and you'll see repetitive stimulation leads to weakness. So the more I stimulate it, the weaker the muscle gets. That's what you're going to see on EMG. Now, what about, oh, by the way, look like this. So you tell them, okay, stimulate the nerve, then you see contraction. Stimulate again, contraction. Stimulate again, contraction. Stimulate again, contraction. Stimulate again. Oh my gosh. The more you contracted it, the weaker the contraction got. So after a while, it doesn't contract much. And that's what happens. At the end of the day, they're really tired. Tell them to keep blinking their eyes, and they get pooped out. They can't do it. All right, now another test, and this is a very popular one, is the edrophonium test, and also known as the Tinslon test. What we're going to give you is edrophonium. We're going to inject you with edrophonium, which is a short-acting anticholinesterase agent. It's a cholinesterase inhibitor. So what happens is, as soon as I give it to you, your eyes open. I can see clearly now the edrophonium is on board. Oh no, I can't. It's short-acting. It doesn't last very long. But that's what I just want to see you get better. If you get better with a short-acting anticholinesterase agent, then I'll put you on a long-acting one. Makes sense, right? So we'll use a short-acting one to make the diagnosis, and then I'll put you on a long-acting one. Okay? Now, what if you're on a desert island? You don't have an EMG, you don't have a lab to test for antibodies, you don't have edrophonium. Well, go to the top of the mountain and get some ice. If you put ice on the eyes for 15 minutes, ice is going to denature the acetylcholinesterase. It'll denature it. So it's like giving edrophonium. Edrophonium will inhibit ACH, the acetylcholinesterase. It'll inhibit it. This will denature it. So the temperature denatures the acetylcholinesterase, and you'll get better. So if I put ice on there for 50 minutes, they're like, oh, now it's better. I can see clearly. And then when it warms, oh, shucks them right back. So that's what we used to do. In the old days, we put ice on it and see if they got better. And that's something the board will do. They'll put ice on there and say it gets better. That's myasthenia. That's myasthenia. Now for treatment, long-acting acetylcholinesterase inhibitors, steroids, immunosuppressor drugs, plasmapheresis to try to remove some of the antibodies, and of course, thymectomy. If you see an enlarged thymus, remove it. Remove it. They get a lot better. Okay, now I want to compare myasthenia, which everyone should know. Let's compare that to Lambert-Eaton, or you can call it Eaton-Lambert, depending on who you like better. This is a myasthenic syndrome. That is the opposite. It is totally the opposite. So if you know myasthenia, this is the opposite. So for instance, it's triggered not by the immune system, it's triggered by a tumor. It's a paraneoplastic syndrome where again you make antibodies, but not postsynaptic. No. Presynaptic. It's against the nerve. Presynaptic. It's the opposite. And it's not against a sodium channel, it's against a calcium channel. So you're going to make antibodies against the presynaptic calcium channel. Now, what kind of calcium channel? Voltage-gated calcium channels. Voltage-gated calcium channels. It's not ligand-gated, it's voltage. As voltage comes out, it opens up the calcium channel. Now, what type? Well, it's not L type. It's P/Q type. This is how picky they're asking it. So, what causes Eat-Lambert? Because of your cancer, your lung cancer, you're making antibodies against presynaptic nerve membrane, voltage-gated, P/Q type calcium channels. That's how specific you gotta be. All right, and again, this is gonna affect the ability. If the calcium doesn't come in, you don't release ACH. If you don't release ACH, you don't get contraction of the muscle. So again, it's gonna lead to weakness. What type hypersensitivity? Type 2. Type 2. And the association is small cell. Small cell lung cancer causes most of the paraneoplastic syndromes. So you're going to be looking for an older smoker who comes in with weakness. That's the opposite. Myasthenia was the small muscles. It got weak at the end of the day. This is the opposite. This is the big muscles, the girdles, the shoulder girdle muscles, the hip flexor muscles. It's the big proximal muscles. And notice, it gets better. The more you use it, the more calcium will come in, the better the release of ACH, and the better the contraction. It's the exact opposite. It's the big muscles, and it gets better the more you use it. When they wake up, they're weak. They can't get out of bed. But the more they use it, the better they feel. At the end of the day, they don't want to sleep. Because in the morning, they'll be weak again. They don't want to count sheep. Even Lambert doesn't want to count lambs. They don't want to sleep because in the morning, they're weak again. Now, here's the kind of weakness they're going to get. They're going to get weakness here, so trouble combing your hair. It's hard to raise your arms. But they get mostly weakness here in the iliopsoas, the hip flexors. So if these are weak, you're going to have trouble lifting your leg. So trouble going upstairs, trouble getting out of a chair. To get out of a chair, you got to use the hip flexors, Well, if these are weak, you're going to use your arms. What's that called when you use your arms to push yourself up? We call this Gower's sign. Gower's sign, it's a sign of proximal muscle weakness. The iliopsoas muscles are weak, the hip flexors. Those are those big hip flexors that help you go upstairs, help you get out of a chair. So again, you're looking for an older smoker who says, in the morning, I can't get out of bed. I can't sit up. I got to use my arms to get up. I use my arms. I can't comb my hair. Can't raise my arms above I can't lift my arms. This is what you're looking for. But the more I use it, the better it feels. So the EMG is going to look like this. EMG, flex it. Oh, it's weak. Keep flexing, stronger. Keep flexing, stronger. Keep flexing, stronger. So by the end of the day, you feel great. You're getting great contraction. Isn't that cool? It's the opposite. Opposite. All right, now let's talk about some skeletal muscle pathology here. Skeletal muscle. First one is like Lou Gehrig's of children. Lou Gehrig's disease of children. Remember Lou Gehrig's? They were doing the ice bucket challenges for adults who have this primary motor neuron problem. Terrible disease. Well, this is like the childhood form. So I want you to remember, it's like the childhood form of Lou Gehrig's, ALS. Now, it's called spinal muscular atrophy. Now, why is the muscle atrophy? It's not the muscle's fault. It's the nerves. It's the infantile primary motor neuron disorder. The neurons die. So the muscle's like, stimulate me, stimulate me, stimulate me. So you're going to get atrophy and weakness because the nerves are gone. They die. Just like Lou Gehrig's disease. Lou Gehrig's is the adult form. This is the infantile form. Now, there's a bunch of these muscular atrophy diseases. They're autosomal recessive. Remember, recessive means 2 mutations. That means you're going to present very early and very severe. Very early, very severe. So they're going to present early, childhood or adolescence, or even infantile in some cases. And the mutation is usually in the survival of motor neuron 1 gene. Isn't that awesome name? Survival of motor neuron 1 gene is mutated so the motor neurons don't survive. Now, where are the motor neurons located in the spinal cord? The anterior horn. That's what's going to atrophy. The anterior horn cells are going to start dying. Now you're going to lose innervation, and you're going to see muscles that have severe denervation atrophy, and you're going to see it all over the place. The whole fascicle, the whole group of fibers, they're all going to start atrophying. So we look at this picture. See this fascicle here? This group here? These are big and juicy. These are good. These are good. These are good. Look at these little dudes. Look at these. They're tiny. They're all like, innervate me, innervate me. They're all atrophying. Isn't that terrible? No wonder this poor kid is having tremendous weakness, because the nerves are not working. The muscles don't work. Now, there's many forms of this disease, but the one form you should know, because it's the most common form, is called Werdig-Hoffman's disease. This is called spinal muscular atrophy type 1. It's the most common. They named it first because they saw it first. This is the infantile or childhood form of Lou Gehrig's, Wernig-Hoffman. Now, it usually starts, it's very severe, it usually starts at birth or within the first 4 months, and you get kids that have weak muscle tone. So they're kind of floppy. It's one of the causes of floppy babies. There's a number of diseases that give you floppy weakness, but this is one of the causes. And of course, these babies are usually going to die in the first 3 years. Very severe form, very severe. So again, there's many forms. Some are later, childhood, some are adolescent. But this is the very severe one. This is the most common one. It kills you within 3 years, just like Lou Gehrig's. Lou Gehrig kills you between 1 and 5 years. Usually, most people are dead in 1 to 5 years. This is dead between 1 and 3 years. Not good. Boo! Don't like anything that kills kids. Now, let's put our sights on 2 groups of diseases: muscular dystrophy, where they do the Deladons, and inflammatory myopathies. So I kind of like that. Inflammatory, inflammation, your immune system is attacking your muscle. So we have 3 of them. Polymyositis, multiple muscles are inflamed. Dermatomyositis, so multiple muscles are inflamed, and your skin, you get skin rash. And inclusion body myositis, so inflammation of muscles with inclusion bodies. I like the names. Now, here are your general rules. All of them are thought to be autoimmune. All of them. We think these are autoimmune inflammatory diseases. Number 2, your immune system comes in, inflames the muscle, and breaks it down. So you're going to get weakness, but it's going to be tender. So they can say, my muscle's really weak, but when I squeeze it, it hurts a little. It's going to be tender because it's inflamed. It's inflamed. So you're looking for tender muscular atrophy. Number 3, they tend to be symmetrical, and proximal muscles are usually affected more than distal. So what are they going to have again if the iliopsoas is weak? Gower's sign. Gower's sign. So here's another group of diseases that have Gower's maneuver. They use their arms to get up out of a chair because their iliopsoas is so weak. Okay, so Gower's. And then finally, all of them are having muscle breaking down. So what's going to be elevated? The muscle markers. CPK goes up, usually the MM fraction. Aldolase goes up. Myoglobin goes up. The muscle markers are going to be elevated. So let's repeat. If someone's weak and I check your blood and CPK, MM fraction's elevated, your muscle's breaking down. You better do a muscle biopsy. So again, because these muscle markers are elevated, that's going to tell us we better check the muscle. We better do a muscle biopsy. It's not going to be the nerves here. The deep tendon reflexes are intact. I'm going to do a muscle biopsy because the muscle markers are through the roof. The muscles are breaking down. So that's the clue to tell you to do a muscle biopsy here. Now, highest yield is dermato. Why? Because it's very similar to polymyositis. It's got the same muscle weakness, but it's got a rash too. So that's what makes it the most testable. We'll do them all, but that's going to be the most testable because there's extra rash they can ask about. Okay, now let's start with the first one. Multiple muscle inflammation. This is an autoimmune disorder where you get direct injury of the muscle because cytotoxic T cells are coming in to attack them. Just they come right in and attack them. So you're going to see in the endomysial connective tissue, that's the connective tissue around each muscle fiber, you're going to see T cells coming in and attacking it. And the reason is these muscles seem to be overexpressing MHC class 1 antigens. They seem to be overexpressing class 1. T cells are the one who's supposed to check that. They come in, they see this overexpression. It's like, what's going on here? And they start killing the muscle fibers. Okay? So again, that's what we think it is. The immune system, for some reason, is overexpressing these class 1 molecules. T cells are coming in to check it out, and they wind up killing your muscles. They just come in and kill it. Now, who gets autoimmune diseases? Women in their reproductive ages. You're going to have tender muscle atrophy, and as I mentioned, it's usually the symmetrical proximal muscle. So I want you to remember girdles, your pelvic girdle and your shoulder girdle. So trouble going upstairs, trouble getting of a chair, you're going to have Gower's maneuver. You're going to have trouble combing your hair because you can't really lift your arms. Very similar to Eaton Lambert. But Eaton Lambert's an old smoker with lung cancer. This is a reproductive age woman. So that's a big difference. Now, another big difference is CPK is through the roof. Aldolase is up, myoglobin's up. So you're going to do a muscle biopsy when you see that. When you do, you see in the endomysial connective tissue, the connectors around each cell, you're seeing CD4 positive lymphocytes, CD8 lymphocytes, CD4, CD8, they're coming in to attack, mostly CD8, cytotoxic. So do you see all these inflammatory cells? Look, they're around the muscle fiber. See them? They're around it. They're around it. They're saying, I'm going to kill you, and I'm going to kill you. And they're just coming in to kill. Look, they're endomysial in this connective tissue in between. So that's what you're looking for, endomysial cytotoxic CD8 cells. Now, this is going to cause myofibers to degenerate, and some of them are trying to grow back. So you'll see degeneration and regeneration. And this is what leads to weakness. The muscle fibers are dying, and then some of them are trying to grow back. Now, you may check in the blood, because autoimmune diseases can have antibodies. Check in the blood, you may see anti-Gel-1 antibodies. I'll explain that in a minute when we talk about dermatomyositis. Now, let's talk about treatment. How do you treat all autoimmune diseases? Steroids and immunosuppression. Okay? So again, think of the patient. Middle-aged woman comes in with proximal weakness. Trouble getting out of a chair, trouble combing the hair, CPK is elevated, so you do a muscle biopsy. You see inflammation, cytotoxic T cells around each cell attacking and killing it. That's diagnostic for polymyositis. Now, dermatomyositis is even higher yield because you get skin rashes too, in addition to the muscle weakness. Again, it's an autoimmune disorder, but listen to the difference. This is immune-mediated attack of blood vessels. This is really a vasculitis. It's really attacking the blood vessels of the muscle. That's the problem. So it's a microangiopathy. You're attacking blood vessels. So that's what's going to make this one different. It's not cytotoxic cells coming in to kill muscle. The muscles get weak because you kill the blood vessels. So you're going to get ischemia. That's what's going to lead to atrophy of the muscles. Now, who gets autoimmune diseases? Women in their reproductive age, but notice, you can also get it in young girls too. So this is women and young girls. So that's kind of different. It can be younger. But again, you get the same presentation of tender atrophy, symmetrical weakness of the big muscles, so pelvic and shoulder girdle, same exact trouble getting up the stairs, trouble getting out of a chair, you use Gower's maneuver to get up, you're going to comb your hair, you have trouble doing it. But what makes this one cool is the rashes they can show you. They often get the rash around the eyes. They call it a heliotrope rash. Now, it tends to be a purple-red color. Now, in this particular picture, it looks more red to me, but some people say it may look a little purplish, so they call it a lilac color. And not only is it red, but do you see the way it's swollen here? You get this edema. So they get this periorbital edema and redness. It's all swollen, like where you'd be crying. Look like she's been crying. She's puffy and swollen there. Puffy and swollen. Now you also get it on your knuckle. The MCP joint, right when you punch somebody. In knuckles, we give that a fancy name. We call it Gautrons papules. Gautrons papules. The same rash on your knuckles. And you also get the rash wherever sunlight hits. So you can get it on the eyelids, but you can get it here, where, right, your chest area here. If you're wearing a shirt like this, you get it right here. And your back, you get it here. They call it shawl sign. So like when a woman wears a shawl, the shawl hangs down like this, they get the rash in that distribution. On the back, it hangs down. That's where they get the rash, like a shawl. So this is basically a light sensitivity. It's kind of like lupus, right? You get photosensitivity, kind of similar. So again, where do you get the rash? Eyelids, heliotrope, very classic, puffy eyelids. You can get it in the shawl area, and over your knuckles, Gautrons papules. Now, very important. Usually affects the skin and muscles, but notice you can also get lung disease too, interstitial fibrosis, and that can lead to shortness of breath. This usually occurs when you have anti-Jo1 antibodies, which we'll see on the next page. Now, why do I need to make this diagnosis? It's autoimmune. Yeah, but about 15 to 20% are triggered by cancer. So when you make this diagnosis, most of the time it's just autoimmune, idiopathic. But 15 to 25% of the adult cases are going to be a paraneoplastic syndrome of lung cancer. So you better know that. You can't miss lung cancer. So if it's an adult female smoker who gets dermatomyositis, you better think for lung cancer, because lung cancer can trigger this as a paraneoplastic syndrome. All right, that's different. The other ones don't have that. This is the only one that has that. Now, what are you going to see in the laboratory? Well, the muscles are inflamed and they're breaking down, so you're going to see an elevated CPK, the MM fraction, aldolase, myoglobin, all the muscle markers elevated. So again, I better do a muscle biopsy. When I do a muscle biopsy this time, I'm going to see an immune-mediated microangiopathy. So do you see this blood vessel right here? Is that vessel? Do you see all the purple dots around it? Yeah. So here's what happens. Number one, immune complexes deposit there. IgG, IgM, and they activate complement. When they activate complement, the complement damages the blood vessel. So do you remember MAC, C5 through C9? Those immune complexes activate MAC, and MAC damages the blood vessel. Now, in addition, around it, you see all these purple dots. So you also have perimysial. That's the connective tissue around fascicles, groups of muscle. So that's the connective tissue like here. Here's a group of muscles here, group of muscles, and you see inflammation in the perifascicular area. You don't see it in between the cells. You see that in the edges, perimysial area. Now, what else are you going to see in addition to these B cells and T cells in this perimysial attracting the blood vessel? Well, when you damage the vessel, you're not going to get blood to these areas. So these fibers at the edges are going to start to atrophy. So the ones at the edges, the ones close to the vessels, are going to start to atrophy first. So this gets a fancy name. We call this perifascicular fiber atrophy. All right, now let me repeat. What do I need to know here? You need to know it's a vasculitis. Your immune system is causing complement-mediated, and T cells are also coming in too, but it's complement-mediated damage, so you're getting ischemia of the fibers at the edges. Perifascicular, notice I made it red. So complement damage to vessels leads to ischemia and atrophy of the fibers at the edges, perifascicular. All right, now I told you I'd talk about this antibody, because again, autoimmune diseases have antibodies. So the classic one that's associated with lung disease especially is anti-Jo1 antibodies, and they like to ask it. Now this is an antibody that's against histidyl transfer RNA. So it's tRNA for histidine. So this is the antibody against tRNA synthetase. That's the enzyme that loads histidine on the transfer RNA. So let me repeat it one more time to make sure this is clear. This is an antibody against the enzyme, the synthetase, that is going to load the transfer amino acid. So it's an enzyme that loads it. It loads the tRNA, transfer RNA. So that's what you're making antibodies against. And again, when you have these antibodies, they usually get lung disease. They get interstitial fibrosis, and they can get arthritis too. So anti-Jo1. Now, is it diagnostic only for this? No. You'll see it with dermatomyositis, and you'll see it with polymyositis too. But I want you to remember the association with lung disease. Now, here's the way I remember it. Dermatomyositis is like dermatomyosarcoma. It's like Miley Cyrus. Do you remember Miley Cyrus was dating one of the Jonas Brothers? If you watch TMZ, she was dating one of the Jonas Brothers. But Jonases, they have purity rings. They're religious. They don't have sex. Miley, she twerks teddy bears. She's like, you don't have sex with me, I'm dumping you. She dumped him. So I remember dermatomyositis is anti one of the Jonas Brothers. She's anti one of the Jonas Brothers. Hey, the more TMZ you watch, the higher USMLE scores will be with me. So dermatomyositis is anti one of the Jonas Brothers. And remember, she's a singer. So shortness of breath. Singer, shortness of breath. Short of breath. Anti-Jo1. Cool. Now you can also see other antibodies as well, but I've never seen them asked on the exam. So there's other ones here associated. This one's associated with the Gauthron's papules and the rash. So when you have these antibodies, you usually get the rashes. When you have these antibodies, this is often associated with paraneoplastic syndrome or juvenile cases. But again, I've never seen them ask it. I've only seen Jo1. That's the one you should give to memory. Now, how do I treat all autoimmune diseases? Steroids and immunosuppressives, and don't forget to look for lung cancer if they're a smoker. Look for lung cancer. Now, here is my mnemonic for this disease. Here's my mnemonic. Imagine a woman is sitting there crying. You ready here? Joe, I thought you were the one, but you're not. I'm leaving you. If I could get out of this chair, but I can't get out of the chair because I have proximal muscle weakness, so I guess I'm staying. So anti-Jo1, you're crying, right? You're crying, so you get a rash here, you get a rash here, crying. Yeah, Joe, I thought you won. I'm leaving you. If I could leave you, I'd go to Ron's house. Go to Ron's, go Trons, go Trons, go to Ron's house, go to Ron's house. No? All right, I tried. I'll sing you a song. I think you'll like it better when it's in song. All right, so that's very high yield. All right, now polymyositis and dermatomyositis were very similar. Similar presentation, similar muscle markers. They're both women. They're both autoimmune. They both have the same weakness. Very similar. Now, inclusion body myositis has a lot of differences. So I kind of remember this is like the opposite because it's probably autoimmune, but it might be degenerative too. It might be a degenerative process too. So it's probably a combo. It's probably autoimmune plus massive degeneration. I'll tell you why we think it's degenerative in a second. Now, who gets it? Well, the other two are women. So who's going to get this? Men. The other two are reproductive age. Who's going to get this? Old. Older men. That's who gets it. Now, it's still similar because you get tender muscle atrophy. You get symmetrical proximal weakness, but you get a lot more distal weakness. So this is like the opposite. It's men, it's older, and it's more distal than proximal. They'll still be Gowers, but what's different is distal. So what do they have trouble with? They're clumsy. They're dropping stuff. They're clumsy. They can't button their shirt. They can't tie their tie. They can't tie their shoes. Distal weakness. So look for a guy who's dropping stuff. Clumsy, dropping. He can't button his shirt, can't tie his shoes because distal is weaker. That's what you're looking for, distal. Now in the laboratory, it's still inflammatory disease, so CPK is up, alvelase is up, myoglobin is up, because the muscles are being injured and breaking down. So again, that tells me I should do a muscle biopsy. So I'm going to biopsy one of the muscles, and guess what you're going to see in inclusion body myositis? You'll never guess. You're going to see inclusion bodies and myositis. Now question, what does this sound like? Endomysial CD8 lymphocytes causing degeneration and this sounds exactly like polymyositis. Sounds exactly the same. But what's different is it has inclusion bodies. So that's the key difference. Otherwise, it looks like polymyositis. Look for the inclusion bodies. They go what we call these rim vacuoles. See these vacuoles inside the muscle? See the holes, the vacuoles? And they got this stuff at the edges. Yeah, this bluish stuff at the edge, this bluish stuff. So we call these vacuoles with this rimming of basophilia. It's blue material. Now, in addition, you can't see it in these pictures, but you see pink inclusions. Pink inclusion is protein. Which protein? It's going to be Congo red positive amyloid. What kind of amyloid? Amyloid from BAP. Wait a second, BAP amyloid, isn't that in senile plaques of Alzheimer's? You got the same stuff you see in Alzheimer's. In addition, you see hyperphosphorylated, isn't that in the neurofibrillary tangles of death? You also get alpha-synuclein, isn't that in Parkinson's degenerative disease? And you get isn't ubiquination part of those neurodegenerative diseases? So that's why we think this is a combo. We think it's immune because it looks like polymyositis, but we think it's also degenerative because you see some of this accumulation of the same stuff you see in Alzheimer's, same stuff you see in Parkinson's. You see very similar features here. So remember this inclusion bodies, these rim vacuoles. Remember the Congo red amyloid made of beta cleavage of the amyloid precursor protein. Remember tau, alpha-synuclein like Parkinson's. Very cool. Now, since it is degenerative, it does not respond well to immunosuppression. So again, we think it's autoimmune. It just doesn't respond well because it has this degenerative quality to it. So that's different as well. So it's males, it's older, it's distal, it's got inclusion bodies, which is different than the other two, and it doesn't respond well to steroids. The other ones respond beautifully to steroids. So this is like the weird one. It's like a different one. All right, now last category are your muscular dystrophies. This is what they do the telethons for, muscular dystrophy. Now, the most severe and most common one is Duchenne's. This is the one you'll see the kids on the telethon, they're doing terrible. Now, Becker's is similar, but it's better. Becker's is similar, but better. And then myotonic dystrophy is where you get this tense contraction. And you get this, you also get atrophy, but you get this contraction, you get this tonic contraction. So that's kind of cool too. It's not very tested, but when they ask it, you shouldn't miss it. So let's focus on Duchenne's, highest yield, but we'll do all three. Okay, now, Duchenne, start with D. Duchenne's, muscular dystrophy. This is the most common and most severe form of muscular dystrophy, and it's severe, it's regressive, and it's X-linked, so it's always going to be boys. Girls, you can't have all the cool autoimmune diseases. We got to get some too. So this is always going to be males. Now, for the genetics, it's X-linked. That makes sense. X-linked disease. And it's a mutation in the dystrophin gene. Duchenne's dystrophin. Now, what's wrong with it? Deletion. So that's how I remember it. Duchenne's is a deletion in dystrophin. So you don't have any protein. No dystrophin protein. Now for Trivial Pursuit, it is one of the largest genes in the human body. The largest gene is called the Titin gene. Titin, that's the largest gene. But the second largest gene is the Duchenne's, the dystrophin gene. Second largest gene. So it's one of the largest genes in the human genome. And it gets deleted in these cases. It gets deleted. Now, normally we need it to make dystrophin protein. It's a very large structural protein, and that's what they want us to know. It's for structure of muscle. Yeah, it's part of the dystrophin glycoprotein complex. In other words, it attaches the membrane to the actin filaments of muscle. It's for structure, it connects it. So if you don't have it, your muscles are going to contract and they're not connected. They're going to break apart because they're not all connected properly. So let's repeat, this is important for stabilizing the muscle during the contraction because it attaches the actin to the membrane. All right, so this is not good. It's also probably important for signaling for the outside environment too. So it probably plays more than one role. But for the exam, structural protein, structural protein. All right, now when you have a defect in this complex, these cells will now tear. So the more I use my muscle, the more I contract it, the more it rips apart. So you're going to be born normal, but the more you use it, the more it rips apart. The older you get, the weaker you're going to get because your muscles literally rip apart. Now, when they rip apart, is the muscle markers going to go up in the blood? You bet they are. Muscle markers are going to go up. So CPK, the MM fraction is going to go up. Aldolase, myoglobin, they're going to go up. So you're going to get atrophy, which is not tender because there's no inflammation here. The muscles are literally ripping apart. No inflammation. So painless atrophy with high muscle markers. Now again, when muscle markers are elevated, what should I always do? A muscle biopsy. We want to do a muscle biopsy. And here's what we're going to say. Absence of the dystrophin protein. There's your key. Now you can also confirm it by doing genetic testing, looking for deletions in the dystrophin gene. That's a good confirmatory test. But on muscle biopsy, we're going to suspect this because we don't see the dystrophin protein. It was deleted. There's no protein. That's why your muscles are ripping apart. Now, some of the muscles will degenerate, they'll rip apart. Some of them will try to grow back. But unfortunately, they're going to break down over time. All right, now here is a key picture. What I want you to notice is inside the muscle, you got your actin and your myosin, right? That's the contractile unit, the actin and the myosin. Well, that's going to attach to the membrane because of this dystrophin protein. Notice it's a very large protein that attaches, and they're going to ask you, it's a structural protein that attacks the actin to the membrane complexes. So it attaches to the dystrophin, the synaptophytes, it attaches it to this complex. And notice this complex is in continuation with the outside of the cell. So this may play a role with signaling from the outside of the cell. So this may play an important role for extracellular signaling. That's interesting, right? So if I'm missing this thing, now my muscle's going to rip apart because there's no connection here. There's no connection. Now question, what if I mutate some of these other molecules? Well, you can get other muscular dystrophies. So if you see mutations in the sarcoglycans, these guys here, or caveolain mutations, caveolain, which is here, well, that's going to lead to what's called limb-girdle muscular dystrophy, where your limbs and your girdle muscles are really weak. That's a rarer form of muscular dystrophy. So again, this complex seems to be very important for this muscular dystrophy. But the most common Duchenne's is a deletion in dystrophin. Dystrophin protein is large, it's structural. It connects the actin to the membrane. Now notice, it's mutated in Duchenne's and Becker's. Both muscular dystrophies have mutations in this protein. So here's the difference. Duchenne's deletes it, gone. Becker's mutates it. So it's still there. It's short, it's broken, but it's still there. So your muscles break apart slower because at least it's there. So that's why Becker's is the same disease, but it's milder. It's milder because at least you made it. At least it's there. It's broken. It's short and truncated, but at least it's there. So it's Becker's is better. All right, now here's the biopsy results. When we do the biopsy, we're going to see ongoing muscle necrosis. No inflammation. And it just breaks down and then tries to regenerate. Breaks down, tries to regenerate. So these guys are normal. These guys are breaking down and trying to regenerate. These small dudes here, they're trying to regenerate. And when you regenerate, you often see central nuclei. So if you ever see muscle with central nuclei, skeletal muscle with central, that's a regenerating fiber. Because mature fibers should have peripheral nuclei for skeletal muscle. If you see central nuclei, that's a regenerating fiber trying to grow back. It's trying to. Notice you'll see variations in fiber size. So these big ones are normal. These small ones are trying to regenerate. You'll see abnormal internal nuclei in the regenerating fibers. You'll see progressive replacement of the muscle as it dies with fibrous tissue and adipose tissue. So notice, this is early on. Here's late. When they start getting weak, I still see some good fibers. This one's regenerating. The rest of them are lost. They've been replaced by fat. Fat and fibrous tissue. Fat and fibrous tissue. There's not much muscle like there was before. So this is at age 3, getting some weakness. This is at age 9, really weak, really small muscle. Now, the way we're going to diagnose this when we do the muscle biopsy is we're going to try to immunostain for dystrophin protein. Now, normally, notice the way you see brown at the edges. See brown at the edges? That's where the dystrophin should be, at the edges connecting, right? Notice this muscle fiber, no brown at the edges, no brown at the edges. So your patients don't have dystrophin. Normally, you should see the brown stuff at the edges. See the edges here? All brown. That's normal. So this is normal. This is your patient. No dystrophin. Now do genetic testing to confirm it. All right, now let's talk about the clinical. This is kind of a sad disease because it's progressive. That's why we do telethons, and they can make all these sad stories because it is a tragedy. These kids are going to get worse and worse. Now, they're normal at birth because you haven't used the muscles much. But as the kid starts crawling and starts walking, he's going to get progressive muscular weakness. So you almost always have signs and symptoms before age 4. You almost always know it because these kids can't keep up with their peers. Their friends are climbing on stuff, and this kid's falling. He's not keeping up. His walking is delayed compared to other kids. He's clumsy. He's falling down. He can't keep up with his friends when they go to the playground. These are the key features. The kid is missing his milestones. Now, when you look at his calf, it looks huge. It looks huge. So if I take a look at this kid, he's having trouble walking. But look at, what are you doing? Nothing but calf exercise? Look at the size of this. This is a monster calf. What are you on the calf machine all day? Look at this dude. Look at the size of the calf. No, John, it's not hypertrophy muscle. It's fatty infiltration. We call it calf pseudo-hypertrophy. Pseudo-hypertrophy. So that's why they look bigger, but they're really weak. You get calf pseudohypertrophy because it's infiltrated by adipose tissue. And I also want you to remember this as an ascending weakness, kind of like Guillain-Barré's, but that was an ascending paralysis. That was the nerves. This is an ascending muscle problem. So first it starts down here. The calves are really weak. They're really weak. They look big, but they're really weak. So these kids have trouble walking. They often walk on their tippy toes because they have really trouble contracting, right? And then the weakness comes here. When it's in the proximal iliopsoas, now the kid starts using Gower's maneuver. You'll see the kid falls down and he gets up by using his arms to get up because the iliopsoas muscle is too weak. He's got to use his arms. And then it will come up to here and affect your heart and kill you from arrhythmia, or your lungs. You'll get atelectasis and get pneumonia and die. So that's a problem. When it gets to the heart and lungs, it kills you. So it's ascending. It comes up and gets weaker and weaker as it comes up. Okay? All right, so let me go back here. So I want you to remember symptoms by age 4. Then when it gets up into the pelvic and shoulder girdles, these proximal muscle weakness, they're going to get in the wheelchair by age 10. So symptoms by 4, wheelchair by 10, bedridden by 15, and they're usually dead in their 20s and 30s. And there's 2 ways they die. The respiratory muscles don't work properly, so you get atelectasis leading to infection, or your heart. Your heart gets arrhythmia or failures because the heart's a muscle too. The heart's going to have problems too. It's going to break down over time too. So that's how they die, the lungs and the heart. Okay? So respiratory and heart, arrhythmias, cardiomyopathy. So let's repeat. Symptoms by 4, wheelchair by 10, bedridden by 15, in the grave by 30. This is very sad, very bad. Now, cognitive impairment can occur too. So sometimes their scores start dropping because dystrophin protein is actually found in some neurons too. Isn't that weird? I thought it's only found in muscle. Well, I guess our brain has some muscle too. We got strong brains because we also see some dystrophin protein in the brain too. So that's why some of these kids will have cognitive problems. Okay? Classic picture, trouble walking because of that calf hypertrophy. Then they'll start using their arms, they use Galvin maneuver, then it gets involved in these muscles too. Now, I was in the gym once, and this guy was on the calf machine for hours. For hours, he wouldn't let me in. And he's got his jeans up around his knees. He's on the calf machine. He's like, doing a calf. And I'm like, dude, can I get in? He's like, no. Then later on, I saw him later on, and somebody asked him, what time is it? And he takes his watch and he puts it next to his calf, and he goes, it's 2:30. Every opportunity to look at his calves. He had like a calf fetish. And I was like, dude, you got Duchenne's. He's like, yeah, Duchenne's. I was insulting him medically, and he didn't even know. He thought it was, oh yeah, Duchenne. It's you, Duchenne. No, that's pseudo-hypertrophy, dude. I'm bagging on you. Anyway, the doctors in the room were laughing. Now, let's talk about a disease that's better. Becker's is better. It's still muscular dystrophy, but it's better. It's a milder form, so it's less common, unfortunately, and it's less severe. Now, it's the same X chromosome because it's the same dystrophin gene. It's exactly the same. It's boys. So why is it better? Because you're going to mutate it, but you're going to at least make it. So you're going to make an abnormal dystrophin. It's usually smaller, it's truncated, but at least you made it. So it's abnormal. The muscle's going to break down, but it's going to take longer to break down because at least you got some structure. Make sense? So that's why it's going to have a later onset and a milder symptom. So here's my rule. If they're still walking at 12, it's Becker's, because Duchenne's is in a wheelchair by 10. So if they're walking at 12, it's Becker's. Now it takes them a lot longer to go in the wheelchair. So they can live a long time. Now they have trouble with exercise. They can't exercise very well. They get cramping if they try to exercise a lot. But they can live almost a normal lifespan because it involves less muscles. It doesn't involve the heart as much, doesn't involve the respiratory as much. You can live a lot longer, but you will get really weak. The older you are, the weaker you get. So eventually you will become bedridden, but it's at least better. You live longer. Okay, last one, myotonic dystrophy. Myo, muscle, tone, and then dystrophy, abnormal growth. It's going to still atrophy. So you get episodes of tonic contraction, but long term you're going to get atrophy. So myotonia is sustained involuntary contraction of a group of muscles. So a classic finding is you go to shake their hand, and they shake you, they contract, and then they can't let go. They can't let go. You're like, dude, that's enough. They don't let go. I guess it's like the president, right? He doesn't let go. They don't let go. It's like really weird. So they don't let go. So I want you to remember, this is a patient who gets a lot of stiffness, and they have inability releasing their grip. So I saw one patient, he said, doctor, I open the door, and then I can't let go to it. Can't let it go. Because once I get that contraction, it doesn't let go. It's weird. Okay, but over time, though, they're still going to get atrophy. They're still going to get weakness. They just have episodes of tonic contraction. Now, the genetics, this is autosomal dominant, so you'll give it to half your kids. And the gene is dystrophia myotonica protein kinase. I love it. A fancy way to say myotonic dystrophy. Cool. Now, why is the board going to ask about this gene? Because it's a triplet repeat. Anytime there's a triplet repeat, they love it. So you're going to see CTG, CTG, CTG repeating hundreds to thousands of times in the 3' untranslated region, the non-coding region, and every time you pass it on, it expands. So you expect to see anticipation. If you pass it on to the next generation, it's going to present earlier and more severely because you repeat it. So here's how I remember it. CTG. Crushing tight grip. Crushing tight grip, or can't let go of your tight grip. So crushing tight grip, that's how I remember it. CTG for this tonic dystrophy. Now clinical, it usually presents in late childhood with gait abnormality. So you have trouble walking. And it's a progressive muscular weakness, usually of the dorsiflexion and hands, the dorsiflexors of the foot and hands. So it's distal. It's more distal weakness here. So well, that's different. It's a little different. This is distal weakness here. Now, the muscles often will contract for no reason, and they're unable to relax them. That's the episodes of myotonia. But long term, they get weakness. Now, when they do get the contraction, if you did an EMG, you'll see myotonic discharges, and then finally it releases after time. Now, what I find interesting about this disease is it looks like they're old. They get cataracts, they get frontal balding, they get endocrine problems like type 2 diabetes, glucose intolerance, diabetes. Doesn't that happen in old people? So I think this is really weird, right? So you get some of this evidence of like early, old age. It's kind of weird. Now they also get testicular atrophy, so they're going to have trouble with getting fertility, and they get conduction defects, so they can have arrhythmias. That's not good. You get arrhythmia that can potentially kill you. But I think this is very interesting, the cataracts. So I can't release your grip, and I'm getting balding cataracts and type 2 diabetes. That's myotonic dystrophy. Myotonic dystrophy. Now, here's the key feature under the microscope. Because again, your muscles are breaking down, CPK is high, we're doing muscle biopsy. Here's what we're gonna say. It mostly affects type 1 fibers, your postural fibers. And what you'll see is a lot of internal nuclei. That means there's regeneration, there's internal nuclei. But the key finding is ringed fibers. Now take a look at this muscle fiber. Do you see at the edges the way the sarcomeres on the outer rim here, they're all lined up circumferentially? Isn't that weird? Now on EM, you see it even better. Here are the normal sarcomeres lined up like this. They're all lined up like this. And then at the edges, they're all lined up a different way. They're lined up a different way. Isn't that weird? They're like a ring, a circumferential ring. So ring around the fiber, ring around the fiber. The outer sarcomeres are oriented circumferentially. That is so cool. So myotonic dystrophy, ring fibers. Now, here's my mnemonic. You're an MD, aren't you not? You're an MD. You're an MD. When you graduate, you're going to get a ring. You're going to get a ring. So MD says, oh, congratulations. You've now graduated. Let go, man. Let go. Let go. By the time you let go, you're bald and you got cataracts. So an old MD can't let go, can't let go, can't let go of those loans, can't let go of the money. Give me the money. Yeah, so that's how I remember it. MD. And crushing type grip won't let go of those loan payments. All right, anything else? Oh yeah, I forgot. I didn't put this on the thing. Peripheral nerve sheath tumors. I think we covered most of these already. So I'm just going to throw these in here at the end. I forgot to put on our summary sheet in the beginning, but that's okay. We did schwannomas already. We did neurofibromas already. So we'll add a little bit of malignant peripheral nerve sheath tumor. Now, all of these are thought to have Schwannian differentiation. So either they're a Schwann cell that goes malignant, or it's a precursor cell that's showing Schwannian differentiation. They all kind of look Schwannian. All right, now let's start with the first one. Schwannoma, it's a good Italian boy. Schwannoma, these are benign tumors. They're benign encapsulated tumors of Schwann cells. Now, they usually occur in adults, and the most common site is on the vestibular branch of the 8th cranial nerve. So we call them vestibular schwannomas. Usually it occurs in the cerebellopontine angle. Now, if it's gonna squeeze my acoustic nerve, my 8th cranial nerve, I'm gonna get ring in the ears and hearing loss. Ring in the ears and hearing loss. Now it's in the vestibular branch, so you're gonna get balance issues too. You're gonna be falling over. And it can also get big and push on the 5th and 7th cranial nerve because it's in that area where they are. So the cerebellopontine angle, if it gets big enough, it push on these cranial nerves, you get facial palsies. Now, since Schwann cells come from neural crest, it's S100 positive. Just like a melanoma, S100 because it's neural crest. Now, most cases are sporadic, just bad luck. But about 10% are familial, and they're associated with neurofibromatosis type 2. Remember NF2, chromosome 22, 2 tumors in the brain, bilateral schwannomas, and meningiomas. Now, NF2 gene is on 22. It makes a mysterious protein called Merlin. We found out Merlin's important for contact inhibition. So when cells grow and they touch each other, Merlin says stop growing. So if I knock out Merlin, now my cells grow and grow and grow, and they grow on top of each other, and you get tumors because you lose contact inhibition. Now, if you ever see bilateral schwannomas, pathognomonic for neurofibromatosis type 2, pathognomonic. All right, good Italian boy, schwannoma. Why do I call it a good Italian boy? Because Anthony A, Anthony B, and Verrucchi bodies. It's a good Italian boy. Now, Anthony A are the areas of the tumor that are very cellular. See all the purple dots? Very cellular. Now, Anthony B are the areas that don't have much cells. See a lot of white space in here? A lot of white space? These are the hypocellular areas because they're kind of barren. So the hypercellular is Anthony A. The barren areas that are kind of whitish, those are Anthony B. But they like this one. Verrucchi body is like a good Italian boy. All the nuclei line up. See the way they're all in a line here? This is a Verrucchi body, when the nuclei line up like that. Verrucchi, it's like a good Italian boy. They queue up. They queue up. Nuclei that are lined up like a palisade, like a picket fence. Prognosis, excellent. If you can resect it, I'll cure everybody. Schwannoma, it's a good Italian boy. All right, now what about neurofibromas? Well, these are also benign, slow-growing tumors of peripheral nerve of Schwann cells. Clinically, they occur in children and young adults. They could be solitary or multiple, especially if they're genetic, they'll be multiple. They can involve the skin, nerve plexus, retroperitoneum. You can see them in the GI tract too, but most of them are going to be in the skin. Now, they can involve long sections of the nerve. When they involve long sections, even just one area, that's easy to remove. But if it involves long sections, they call it a plexiform neurofibroma. Those could be hard to remove. And when I see plexiform ones, it's almost always a genetic disease. It's always neurofibromatosis. We see plexiform ones. Now, for the genetics, I want you to remember neurofibromatosis type 1, but they also occur in type 2 as well. They're just more common type 1, which is mutations in NF1, which is on 17 letters in von Recklinghausen, 17 letters in neurofibromatosis. It makes a protein called neurofibromin, which is supposed to inhibit RAS. So if I'm born with an NF1 mutation, I don't have neurofibromin, I don't inhibit RAS. If you leave on RAS, you're going to get tumors. So you're going to get multiple disfiguring neurofibromas. They can be large and plexiform. That's classic. You're also going to get optic gliomas. You're going to get pigmented lesions called caveole and axillary freckling. You're going to get pigmented iris hematomas called Lisch nodules. And don't forget, they can also get, since the NF1 is also knocked out in pheos, they can also get pheochromocytomas as well. Now again, neurofibromas can happen in type 2 as well. So neurofibromatosis type 2 will have neurofibromas as well, just less than type 1. Okay, here's what they look like. Under the microscope, they're composed of Schwann cells mixed with fibroblasts. Oh, neurofibroma. Got it. Schwann cells and fibroblasts. Also some mast cells too. Notice they'll have CD34 positive spindle cells. That's a marker of like immature cells, like stem cells. Now these cells are going to be very bland, hard to even see them. So if we take a look here, see the pink collagen bundles? And see these little purple dots? You can barely see the cells. Little purple dots, those are the Schwann cells. They're very inconspicuous, hard to see these cells. So you're seeing these spindle-shaped cells in the thick collagen bundles. Now, when they're large, do you see the way they're large like this? Large. These are called plexiform. These are large, multiple fascicles being involved here, infiltrated by tumors. And unfortunately, these large ones are genetic, and these large ones have a risk of turning malignant. So anytime somebody has genetic neurofibromatosis, neurofibromas are benign, but there's about a 3% chance that the large ones will turn malignant. So you always have to watch them because they could develop a malignant peripheral nerve sheath tumor. This is the malignant variant of these peripheral Schwann cells. It's the malignant variant of them. Now, who gets it? Well, it can be children and adults, so anybody can get it. They can arise by themselves, or they can arise from a plexiform neurofibroma. That happen de novo or because it runs plexiform. Now, half of them are going to happen with neurofibromatosis patients. And like most malignant tumors, they're poorly defined masses. Under the microscope, you'll see spindle-shaped sarcoma, ugly-looking cells that are very cellular. And because it's malignant, you'll see mitosis and necrosis and anaplasia. Not cool. Now, it's going to infiltrate like crazy. But what's kind of interesting is sometimes the tumors try to take on muscle differentiation. So every once in a while, you see a couple of funny looking cells that have cross striations. And you're like, dude, that's a skeletal muscle. Yeah, we now call it a Triton tumor. Triton tumor is a malignant peripheral nerve tumor that has evidence of muscle differentiation. So I just think that's cool. Triton tumor is when you start seeing these muscle differentiation. Again, for step exams, I didn't make it red because I never heard them ask it. But it's kind of cool to know. Malignant tumors of the peripheral nerves can sometimes have evidence of muscle differentiation. Okay, we did it. Good news, only one chapter to go. CNS, and that's it, then we're done. So I've really enjoyed hanging out with you guys. So CNS is a big chapter, we'll be together for more time, but I just want to tell you how much
You people are amazing.